So X-ray emission is going to be chapter 9. So I'm going to just kind of talk about the factors, and then I'm going to bring this up and we'll take a look at the BRIM spectrum. If you remember from spring semester, the BRIM spectrum, the factors that affect BRIM spectrum are the factors for emission in both emission and also absorption in the patient. So if you can wrap your mind around the BRIM spectrum, then in as much as imaging, image receptor exposure and things like that, it makes it a whole lot easier. So that's where we're going to start. So we're talking about emission from the X-ray tube. We're talking about quantity and quality. So quantity, what we use to control quantity. What we use, of course, is mass, but there's a whole lot more to it than just mass. If you remember from the spring semester, kVp greatly affects quantity as well. It's not what we use to control quantity, but it is a factor that affects it. So pretty much anything that we do can affect quantity. So the quantity would be kVp, mass, amount of filtration, generator type. All of those things can affect the quantity of the X-rays that we create. So quality, though, is a little bit, when we're talking about quality, we're talking about X-ray beam quality in this context. It's not radiographic quality. That is going to be, you know, your contrast and density, but the quality of the X-ray beam is what we're going to focus on right now. So really the factors that affect quality would be everything except for mass, essentially. So we're talking about kVp, anything that increases either the peak or the average kVp. So it would be kVp, filtration, and machine phase. So quantity, again, is intensity. That's just the number of X-rays that you create, and it's controlled by the tube current. So as you increase your MA specifically, you increase the space charge, you increase the thermionic emissions, and once you make your exposure, the electrons travel across the tube, and that's where you get your mass. So what we measure that in is gray in air, and sometimes we refer to that as a Rinkin. So if you ever hear MR with a capital R, that's millirinkin. Some of your physicists will give you a report in either one of those two, either milligray or millirinkin or Rinkin output from the X-ray tube. So every year, and we'll talk about this throughout the semester, every year, at least once a year, a physicist has to come in and test all the equipment to make sure your kVp is right, make sure the mass that you set is the mass that comes out of the X-ray tube. And have to make sure that the collimators are accurate, and a number of other things that we'll talk about throughout the semester. But after the physicist is done, you'll get a report that gives you what the output of the X-ray tube was, and it can be measured in either one of those. So the factors that affect quantity, you know, this is where it gets dicey and it gets a little bit difficult. And after we run through this, I'm going to shut it down and we'll draw it on the board. So the relationship between mass is direct in every way. You increase your mass, you increase the output from the X-ray tube. You double your mass, you double the output from the X-ray tube. You triple your mass, you triple the output from the X-ray tube. It's just a quantity of electrons you send across the tube, and that translates directly into the quantity of X-rays that you create. So the more electrons you send, the more electron interaction you have on the target, and the more X-rays you create. So it's direct in every way. You increase one, you increase the other by the exact same amount. In my drawings here in a bit, it's not going to bear that out, but you know, I can't really draw it to be perfect, but you'll get the idea. With kVp, though, it's exponential. Now how you remember this is direct and it's exponential. And how you remember this is with your 15% rule. So if you want to maintain image receptor exposure and reduce patient exposure, if you increase your kVp, then you get more penetration, right? And we're going to talk about this in the next slideshow, but you increase penetration, and anything that either keeps X-rays from interacting in the patient or with the patient, or anything that causes the x-ray to go through the patient without being absorbed in any way. In other words, increased penetration without interaction reduces patient dose, right? So what does kVp do in that? You increase kVp, and what do you get more of?
Scatter.
You get more scatter, that's one. So scatter is partial absorption, which adds to patient dose, but you also get more penetration without any kind of interaction, right? So as we increase kVp, we have the potential of reducing patient dose. All right, so full stop on that. If we increase kVp by 15%, how does that translate to image receptor exposure? What do we get at the image receptor? Dose. Yeah, it doubles it. So if we increase kVp by 15%, then we're gonna get more patient exposure, and we're gonna get more image receptor exposure. If that's the only thing that we do is increase kVp by 15%, both of those things are gonna go up. But if you don't want to double image receptor exposure, but you want to increase kVp by 15%, what can you do?
Offset your mass.
Opposite mass by 50%. So you're going to cut your mass in half, and in that way, your patient dose will actually go down. So will it go down from your original technique? And the answer is no, it won't. So your original technique, you've got a certain amount of patient exposure. If you increase your kVp, and that's the only thing you do, your patient exposure is going to increase. Not as much as if you increase your mass, but it's still going to increase. If you cut your mass in half, your patient dose is going to come down. All right, so your dose was here, you increased your kVp, and then you reduced your mass and brought your dose down. Okay, so kVp is exponential. It's direct and it's exponential. So the reason I went through all that little exercise is that a 15% change in kVp equals a doubling of mass, right? So it's exponential, where mass, you increase your mass by a factor of 2, you get an increase in the image receptor by a factor of 2. With kVp, you get an increase, with a 15% increase in kVp, you get a doubling at the image receptor, right? It's not one for one. Still goes in the same direction, so it's a direct relationship, but it's exponential, right? 15% equals 100%. Machine phase, I get it. You're never going to, probably every machine that you're working with in the hospital is high frequency. So chances are, you're never going to work with a single phase or a 3-phase 6 or 12 pulse. You're just not going to, but you have to know this for the registry. With machine phase, what you get is an increase in quantity, but it's not, it is direct, but it's not direct in every way. Okay, so it goes in the same direction. If you go from single phase to 3-phase, you get a greater output from the X-ray tube. You remember how much it is?
2.
In fact, very good, factor 2. I knew somebody was going to say 3, which would just be too logical. Single phase, 3-phase, factor of
2.
Yeah, it should be 3, but it's 2, right? So if you go from single phase to high frequency, it's about 2.5. So it's slightly more, not significantly more, but it's slightly more. So there's that. And then with filtration, we get a couple of things. One, that it's a inverse relationship with quantity. So as we increase filtration, if you were to add another layer of filtration, then we would lose photons coming from the X-ray tube. So what's the minimum that you have to legally make an X-ray on living tissue? 2.5, very good, 2.5 millimeters of aluminum equivalent. And that equivalent is an important factor in that it doesn't necessarily have to be aluminum. Everything that it passes through can be calculated to determine its equivalence in aluminum. So what's the first thing it goes through? The glass or metal envelope, and then the thing that cools the glass or metal envelope, and that is the oil, and then it goes through the port, and then it goes through the mirror. So if going through all of those gets us to 2.5 millimeters of aluminum equivalent, then we don't have to have anything else. So a couple of things on that. One is filtration. For our purposes, and this hadn't changed since second semester imaging, for our purposes, we're going to consider anything that you can't take away from the X-ray tube, or that's physical, or that you can't take away and legally make an X-ray. We're going to consider all that inherent filtration. So that 2.5 millimeters of aluminum, we're going to call inherent filtration. Tanning of the X-ray tube, which is going to increase our filtration over time, is also going to be inherent filtration. It's increased inherent filtration, but it's inherent filtration. So what it does is it inversely affects quantity, and it increased filtration decreases photons, but it increases overall quality. So so other factors, SID changes. There's inverse proportionality, and that's the inverse square law. It's second to kVp to be in the most significant change in quantity. Changes in OID because of the air gap. We just saw both of those things. Changes in grid ratio, changes in tissue thickness. As tissue thickness increases, we get less exposure to the image receptor. Changes in tissue density. So we got bone versus soft tissue versus air and all of that. Okay. So I'm gonna mute these, or at least one of them. I'm gonna bring this up. Some light back in here. We're going to talk about the brim spectrum. So if you remember, and I know it's been a minute, but if you remember, the brim spectrum is the emission spectrum. Yeah, it still works, but not a whole lot there. The emission spectrum, and this is emission from the X-ray tube and not emission at the anode. So I'm going to draw the anode first, and then we're going to talk about everything else. All right, so we've got 4 essential factors that affect emission from the X-ray tube before we need to make adjustments for SID, tissue thickness, and whatnot. Okay, so let's say we have the same technique on all of these roughly, and then we're going to change them. Okay, so we're going to start off with a baseline technique of maybe 75 kVp at, let's say, 32 mAs. Okay, so if we make an exposure on that, our brim spectrum at the anode before it gets to the glass, what we're going to have is a brim spectrum that looks like that. That's an unfiltered X-ray beam. So what we create, if you remember, all the way back to X-ray creation in the first semester, because we're firing electrons at an atom. An electron, if you remember, it has an atomic mass of 0 at the nucleus of the atom, and that's tiny as well. Most of those electrons are going to pass at a distance from the nucleus of the atom that you're not going to create X-rays. You're going to create, it's the main thing we create an X-ray tube. Heat, right. So most of them are just going to create heat. A few of them are going to create high energy X-ray photons. And then most of them, the remainder are going to be somewhere in the middle. So most of them are going to pass at a distance that they're going to be such low energy. This would represent our 75 kVp here. This would effectively represent 0, and this is the number of X-rays that we create. So we're going to create a whole lot of useless X-rays and very few of our peak energy X-rays, right? But again, the first thing that it goes through is that glass or metal envelope, and it's going to absorb some of those low energy X-ray photons. And then it goes through the oil, and it's going to absorb more, and then it's going to go through the housing, the port housing port, and then it's going to go through the backside of the mirror. And what we're left with is something that looks more like that, and that would be your brim spectrum. What if you're looking at a spectrum and you've got a spike on it right there, that spike represents 69.5 kVp, which is your characteristic spectrum. This all kind of ringing a bell? Mm-hmm. Okay. So when we change our factors, again, we're going to focus on kVp, mass, filtration, and machine phase. All right, so let's start with kVp. When we change kVp, you know, I know that we preach kVp equals quality and mass equals quantity, right? But when you change your kVp, if you increase your kVp, that's that one. That's better. If you increase your kVp, we have a tendency to think, okay, well, we're just going to add X-ray photons down there, right? That's not how it works. If you increase your kVp, you're going to increase, you know, you can't aim the X-rays, so you can't aim, or I'm sorry, you can't aim the electrons at the nucleus of the atom. So what you're going to get is this same distribution that you had before. You're just going to have more of it. So if you change your kVp, we're going to leave our mass the same, and we're going to say, make it more obvious, 100 kVp. Then our brim spectrum is going to start up there, and it's going to come down, and it's going to hit 100 kVp down here. Okay, so just immediately before we get to the filtration, what do you see there? If this represents numbers, what do you see there?
A lot more.
A lot more, right? So what you need to be thinking is that kVp doesn't just increase the peak energy, but it increases all X-ray creation at all energy levels. So if we were to follow this out, then what we would get is a brim spectrum now that shows a lot of different stuff. One, it shows a higher peak energy, but we get an increase in numbers, right? We get an increase in numbers. If you remember, and I didn't draw this again perfectly, but if, you know what, let's do this. We're going to change that from 75, and I'm sorry if you're counting on these numbers, but we're going to change that to 60, okay? So it's 60 kVp on this one, okay? So with 60 kVp, you don't have a characteristic spectrum, right? Because we only count K-shell interaction. So when we change from 60 to 100 kVp, we got an increase in numbers, we got an increase in peak energy. We also now have a characteristic spectrum at 69.5. But if you remember, our average energy is always 1/3 of our peak energy. So what's 1/3 of 60? 1/3? 20. Yeah, somebody said 40. 20 kVp is our average. What's 1/3 of 100? 33, right, so 33.3. So we get an increase in peak energy, we get an increase in numbers, and we get an increase in the average energy. So even the average energy is more likely to penetrate through the patient than what it was at 60 kVp. We get everything increases. Okay, so we get a whole lot more X-ray photons. That's why when you increase your kVp, you get an increase in patient exposure. You get an increase in patient exposure. You get an increase in numbers. It gives you an increase in patient numbers. You get an increase in peak energy. You get an increase in average. It pushes the brim spectrum towards the high energy side. Okay, so that's kVp. With mass, let's do the same thing with mass. Mass, and I'm not going to draw the raw spectrum, but you've got here, and our peak energy is 60 kVp. When you increase your mass, we go from 32 mass in this case. Let's say we're going to go to, 100 mass. So what's going to happen to our peak energy as we increase mass?
You're adding more. So
You're adding more.
So it's still going to go up.
The peak energy,
No. You're saying.
you just add numbers, right? So what is mass? It's milliamperage seconds. What's an amp? It's a count of electrons. You're sending more electrons across the tube, translates into more X-ray photons, but it doesn't do anything to the numbers, right? Doesn't do anything to minimum energy. Oh, let me back up just a second. kVp has no effect on the minimum energy, okay? So it increases the numbers, it increases the average, and it increases the peak energy. So when we increase our mass, the only thing that happens is we get a bigger bubble. Peak energy remains the same, the minimum energy remains the same, and all that we're going to get is an increase in numbers. So this was the 32, this is the 100 mass, we get an increase in numbers. Okay, it's 1 for 1. You know, if you have 1 mass, you change to 2 mass, you have twice as many, right? You have 2 mass, and you change to 4 mass, you have, again, twice as many, right? So it's a direct relationship all the way across the board. kVp, direct, increase and increase, but the increase is exponential. With mass, increase and increase, but it's direct. So let's go with machine phase. Let's do that first. So with machine phase, what we have is, again, we got the same technique on both of these. So both of them are going to be 60 kVp at 32 mass, okay? So with machine phase, what we get is a increase in numbers by a factor of 2 if we go from single phase to 3 phase. But if you remember, what we get in change in machine phase is that you know, single phase unrectified waveform looks like that. If we rectify it, we take off that bottom portion and we put that, invert it, and put it here. Right? Remember all that? So we've got then twice the output between single phase unrectified and single phase full wave rectified. But once we go to 3 phase, we kind of spackle that gap in. So what this value right here represents is effectively 0 kVp. All right, that's 0 kVp. So that doesn't look like OKVP. 0 kVp. So does our overall waveform get to 0 once I go to 3 phase and I start filling in these gaps? No, it does not. All right, so I usually use the analogy of test grades. You know, if you know, you have a number of test grades and some of them are 0 and we throw the zeros out, what happens to your test grade? It goes up. So that's your, that's your average in the class. The average in the class goes up. And so how that translates here is that once we go from single phase to 3 phase, our peak remains the same, our minimum remains the same. We get a doubling of the numbers, but if you notice, we've got a slight change in the position of our average. So our average increases, numbers increase, so the output from the X-ray tube increases. And we've got to adjust our technique by a factor of 2. I did this the other day. Okay, everybody good with that? Okay, so then we've got filtration, which I kind of already drew over here with filtration. Unfiltered X-ray beam looks more like that. You go through the glass, you go through the oil, you go through the mirror, and each one of those drops the numbers, so you get a decrease in numbers, but you get an increase in average. You know, if you were to average out from 0 all the way up to 100, then you know your average is going to be quite low. But if you eliminate all those low energy X-ray photons, and then what you're left with is a higher average. So what we get then is a decrease in numbers, increase in quality. Okay, so what we got here was an increase in numbers, increase in quality. okay? So you're gonna have a tendency, well, and over here we got an increase in numbers, a drastic exponential increase in numbers, and an increase in quality. So what you're gonna have a tendency to do on the test is you're gonna have a tendency to kind of conflate all these things, all right? So with kVp, you get an increase in kVp, you get an increase in numbers. Increase from single phase, three phase, you get an increase in numbers. With increase in kVp, you get an increase in quality. Single phase, three phase, you get an increase in quality. But once you get down to filtration, it flips just a little bit. With more filtration, you get more quality, but you get fewer numbers, okay? So this is gonna be your sticking point on the test. Increase filtration, quality goes up, quantity goes down. And mass is just all about numbers. As we increase our mass, we just increase numbers. That's a direct relationship. So probably the two most common things that people have a difficulty with is kVp, because we stress so much kVp equals quality, but it also equals an exponential change in quantity. So that's the one thing. And the other thing is filtration. With the increased filtration, you reduce your quantity even though the quality goes up. Okay? All right, so let's go ahead and drop these back down, this one back down. So the other things that'll affect quantity at the image receptor, you don't see this a whole lot, but post-patient collimation, we used to have, and I don't know if they still do or not, but they used to make dedicated chest units that were what were referred to as scan projection radiography. And what they had was it's kind of like a single slot grid, and it used a fan beam that would kind of scan the patient from side to side. You might have seen something that might represent that in a sci-fi movie where they, scan the retina or whatever. But it was a fan X-ray beam that would scan from one side to the other, and then right before the image receptor, you had this very thin collimation that would follow the X-ray beam and collimate the X-ray beam post-patient. So it's kind of like a single shot grid, and really the only place that you really see that anymore is in CT. At UT Maine, we used to have a dedicated chest room, and that's where they would use that scan projection radiography. And even that chest room didn't use scan projection radiography, it just used an area beam. So it's for scatter cleanup. So again, it's kind of like a single shot grid, and then grids definitely reduce the image receptor exposure or the quantity of the image receptor. So beam restriction, also, as pre-patient collimation, we've got the three different types. You probably only are familiar with one, that being your variable aperture diaphragm, your collimators. You just don't see cones and diaphragms all that much anymore, but they prevent scatter from being created. So if you prevent the scatter from being created, then it's going to reduce the amount of image receptor exposure, okay? So if you reduce the amount of image receptor exposure, let's say you make an exposure on a KUB, let's say, and your index number is perfect for a KUB, and then you collimate in for an AP of the L spine, how's that going to affect your image receptor exposure? You prevent some from interacting in the patient. What's that? It's going to decrease it, exactly. So, and you can kind of prove this out at clinicals. Mock yourself up a patient, get you a basin of water, put something in it to represent a bone, make an image of the entire basin of water, and see what your phototimer shoots with. And then collimate down to just what it is that represents a bone and shoot it a second time, and see what your AECs give you on the second collimated image. It should increase, and it should increase because as you increase your collimation, you're going to lose image receptor exposure. So it also prevents the scatter radiation from being created, which also adds to your index number. All right, so we just kind of did this. Quality, kVp, as we increase kVp, we increase beam quality. Increase filtration, we increase quality. Generator type from 3-phase to, or single phase to 3-phase, we increase beam quality. kVp, we get that increase in peak energy. Inherent filtration, again, is going to be anything above or anything that brings us to 2.5 millimeters of aluminum equivalent. And what that leaves us with is mainly compensating filters, which are, again, going kind of the way of the dodo bird, because our computer algorithms are better at giving us the anatomy that we would have had a hard time seeing without compensating filters before. I'll use an example of a foot. Back when we were using screens and films, you had to shoot the foot for where the patient's pain was. If they ordered foot and they, the patient maybe dropped something heavy on the distal portion of the metatarsals, then you would select a totally different technique than if it was closer to the ankle. And that would be because you couldn't see the entire foot all in one image. Not with one technique, you couldn't see it well. So we had to have different techniques for different parts of the anatomy. Or we could use a compensating filter, a wedge filter, that would compensate and even out those tissue density differences. You just don't need that anymore with DR. It kind of takes the place of that. So that would be an example, though, of additive filtration. One thing you're going to have a tendency to want to flip around is additive filtration in context of tanning. So tanning is added filtration, but you can't remove it from the X-ray tube. So it's added inherent filtration, right? So lock that into inherent filtration. Inherent filtration does not remain the same over the life of the X-ray tube because of tanning. So your brand new X-ray tube is going to have 2.5 millimeters of inherent filtration. A tube that's 10 years old may have 3.5 millimeters of aluminum equivalent. Okay, it's still inherent filtration because you can't go in and clean it out. It's still inherent filtration. And you may want to make the mental gymnastics of, well, why don't we just remove some of the other inherent filtration to bring it back down to 2.5? And the answer is, because we don't. That's all there is to it, we just don't. So 2.5 millimeters of aluminum, brand new tube, it will increase with time because of tanning. So, all right, so half value layer is worth stopping on for a second. And I can kind of draw this out if you need me to, but half value layer is a better measure of beam quality than what is kVp. kVp is what we use to affect a change in beam quality. But half value layer is a better measure. Okay, so if you have two X-ray tubes, one's a brand new tube, it's got 2.5 millimeters of aluminum equivalent, right? A year later, the output of the X-ray tube is naturally going to decrease. Okay, so you set 100 mass on a brand new X-ray tube, and they measure that your mass is actually 100 mass. A year from now, they take that same measurement tool and put it in an X-ray beam and make an exposure of it. It's not going to be 100 mass. Why?
Because more filtration.
More filtration because tanning, right? But it has what you have set on your control panel has to match what that detector reads. So what they're going to have to do is they're going to have to go into the system and they're going to have to adjust it and tweak it a little bit so the output from the X-ray tube reads 100 mass. So thinking back at our drawing of filtration, we've got the same output, but what happened to our average energy? Push it to the high energy side, right? So we've still got 100 mass, it's just a better quality X-ray beam, right? So every year they got to come in and do that. They have to measure as what they call MR to MAS output test, and they're measuring how many MR am I getting for the amount of mass that the machine says I should be getting. So they're going to do that every year, and every year they're going to have to adjust it a little bit so that now you've got a 6, 7, 8-year-old X-ray tube, has a very high quality X-ray beam compared to that brand new tube, but it's still giving you the same number of photons, okay? But with that higher average, can you kind of see how it would be more penetrating? With the higher average, you get a more penetrating X-ray beam, right? So with that more penetrating X-ray beam, why do we say kVp controls quality? Why do we use kVp to control quality?
Because you're controlling penetration.
You got to have penetration, right? So an X-ray beam that doesn't penetrate has no quality at all. So the higher the kVp, the better, the higher the quality of the X-ray beam. So we're using the same technique between the old room and the new room, but the old room has more penetration. If penetration equals quality, then that old tube is giving you a higher quality X-ray beam. It's more penetrating, so the half value layer is going to be higher. So what half value layer is when they're doing those QA tests every year, they'll take sheets of aluminum and they'll put that same radiation detection device and they'll make an exposure, and maybe a brand new X-ray tube, an additional millimeter of aluminum might cut our output from the X-ray tube in half. Okay, so it's just spitballing numbers, but it's let's say it's 1 half value layer. So 1 millimeter of aluminum is a half value layer in this case. The old tube might take 2. Because we have a higher average, it might take 2 millimeters of aluminum. So its half value layer is 2 millimeters of aluminum. So the higher the half value layer, the more quality we have in the X-ray beam. Got that? So in that way, half value layer is a better measure of beam quality than what kVp is. kVp is still valid, and it's what we use, but half value layer is a better measure of beam quality.
So, especially when there's 2 machines, maybe one's 5 years old, and they've done that test on the MA, whatever, you can use the half value layer because that takes into account not just kVp, but the other stuff, because they had to change that.
Yeah, it takes into consideration the penetrability.
Right, okay.
Yeah. So what they'll do is they'll measure just the output, and then they'll do the half value layer.
Yeah.
It may or may not do half value layer. I'm not sure it's a requirement to do it because you're going to get a safer beam every single year that you use
And
the
that's
tube.
all because of added filtration.
It's all because of the tanning of the tube and the increased inherent filtration. Yep. Okay? Everybody good with that? So we drew that out, so no reason to go back with it. Half value layer, just a graphic on half value layer filtration, we drew that out. Total filtration, you've got the envelope. It's just the tube. There's a fancy name for the glass or the metal here. The port is this thing right here. So you have to have something that holds the oil in here, right? So that's your port, and then the mirror, the backside of the mirror in a lot of cases is silver. So it's going to absorb some X-rays. So if your if your filtration inherent in the tube, the oil, the port, and the mirror bring you to 2.5 millimeters of aluminum. That's all you need. If it doesn't, then we have to have more. If it only brought us to 1.5 millimeters of aluminum equivalent, we would need another millimeter of aluminum to be within regs. It's got to be 2.5 millimeters of aluminum. Okay? So any questions?